Friends, welcome to my workplace at Ranaghat, West Bengal, India for hands-on Phaco and SICS training. Let us observe this surgery. This is a hard cataract. This is the main incision with a 2.8 mm steel keratome on the posterior aspect of the limbus. And now this is a sideboard on the left side of the main incision about 3 clock hours away. And now the anterior capsule is stained with trypan blue dye because this is a white cataract. The dye should touch on all parts of the capsule for uniform staining. And if we stain it underneath an air bubble, the dye is concentrated and sits over the anterior capsule and staining is very fast. The dye is washed out with bases. Then the anterior chamber is filled up with 2% hydroxypropyl methyl cellulose. And now Capsulorhexis is done with a Utrata forceps. In this case, there is convexity in the anterior surface of the lens, and here it is. It goes to periphery. And now see how I retrieve this. 2 jerky pull and it comes on track. And as the antechamber becomes shallow, some more jerky pull to complete the rhexis. Watch it in slow motion. Here at around 9 o'clock, it goes to periphery and it is entangled in the zonule. Hold it and 2 jerky pull. Watch it. 1, 2. 2 jerky pull, 2 quick pulls, and it comes on track. And as the antechamber becomes shallow, I put some more jerky pulls to complete the rhexis. This is not a round rhexis, but it is a CCC, continuous curvilinear capsulorhexis, and we need not convert to SICS. We can safely continue Phaco. And this is a hard nucleus. Nucleus sclerosis is grade 5, very thick, very hard nucleus. And in this case, as I do my technique submarine chop, I'm going to continue with that technique. The Phaco needle goes in, some superficial cortical lens matter is removed, then the handpiece is turned to make the bevel up. The nucleus is pushed little down and the tip is buried into the substance of the nucleus. It goes through the substance of the nucleus towards the opposite equator, and the chopper is used to get a nice crack, and gently the crack is enlarged, but not too much lateral separation. 180-degree rotation, come to the other side. This was a very thick nucleus, so I sculpted it a bit to go to deeper level and lateral separation was done. 2 heminuclei achieved. Each heminucleus is now subdivided into large fragments. This large fragment is sealed at the apex and emulsification is started. Done. One large fragment is managed. Come to the other large fragment, tilt the large fragment, start emulsifying from its apex. If necessary, we can divide it into smaller pieces, and then I am doing it very slowly because there is nothing to protect the posterior capsule. This is the other heminucleus. It is subdivided into 2 large pieces, and then each nuclear fragment is emulsified. Stability of the anterior chamber should be good in such cases, and we should do emulsification bit by bit so that even if we catch the posterior capsule, we can get time to use reflux and release the posterior capsule. I have done it several times. Another safer option at this time is come out, inject the lens after injecting visco, and over the lens emulsify the last piece. That is called IOL scaffold technique, very safe technique. But in those cases, removal of the cortex becomes a little tricky, but it is not impossible. And now cortical cleanup is done. I am using a Simcoe cannula. It is very safe to use a Simcoe cannula, and I have only one side port, so either I have to use a coaxial IA or this Simcoe cannula. I prefer Simcoe. And now I go through the side port and remove the subincisional cortex. The width of the side port is 1.7 millimeter, and it reduces some amount of astigmatism induced by the main incision. And now hydroimplantation of a single piece monofocal intraocular lens is done. If we use visco, we have to thoroughly clean it out and it will take a long time. But with hydroimplantation there is no visco. The lens goes in the back very easily. With the irrigating probe itself, we can dial the lens, place it as we want it, and as the irrigating probe dials the lens, whatever viscose there in the lumen of the cartridge comes out. This is moxifloxacin. Now the side port is closed by hydrating corneal stroma. The main wound has been constructed in such a way that it doesn't require any hydration. And see the wound, there is no wound burn even with this hard nucleus. There is no wound burn. This is the beauty of easy tip. The antechamber is lavaged for the last time. It is formed very nicely. Few drops of moxie is applied over the ocular surface. Integrity of all the wounds are checked, and then the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.